Hello, everyone, and welcome to the May 2025 edition of Eversight's webinar series, Management of Limbal Stem Cell Deficiency. Just a few housekeeping items before we get started. This webinar and all of our webinars are recorded and available on demand on our website. Also, please keep an eye on your inbox for more webinars coming this year. All participants are muted throughout this webinar, but please do ask questions at any point using the Q&A panel. Questions will be addressed at the end of the talk. At the conclusion of this webinar, you'll also be provided a brief survey and your feedback is encouraged. Now on tonight's speaker. Dr. Sophie Deng is a professor and co-chief of the Cornea and Uveitis Division at UCLA Stein Eye Institute. Dr. Deng specializes in corneal and external ocular diseases. She earned her medical degree at the University of Rochester and completed her ophthalmology residency at the Illinois Eye and Ear Infirmary. She then completed her cornea fellowship at the UCLA Stein Eye Institute. As I mentioned, she's currently at Jules Stein as a professor and co-chief, but is also the director of the Cornea Biology Lab, where her research focuses on corneal epithelial stem cell regulation, deficiency, and regeneration. Without further ado, I will turn the floor over to Dr. Sophie Deng.
Thank you so much for the kind invitation, and it is my pleasure to share with you what we have learned about limbal stem cells. And so this is my disclosure, and I do receive grants from the National Eye Institute and the California Institute for Regenerative Medicine. So my talk is going to be divided into three parts. First is going to be on the diagnosis of limbal stem cell deficiency, followed by management of the disease, and then we'll talk briefly about where we're heading. So limbal stem cells are a set of the adult stem cells that reside in the limbal region of the eye, and they're specifically believed to located in the basal layer of the limbal epithelium. So when these cells proliferate, differentiate, and they migrate onto the central cornea and further differentiate into the mature cornea cells. When the niche of the stem cells or the stem cells themselves are damaged, that will lead to a condition called limbal stem cell deficiency. This disease can be caused by multiple etiologies, either by primary, the genetic etiology, or secondary, or acquire insult, such as chronic inflammation, damage from topical medications, surgeries, chemical burns, thermal burns, infection, and other causes such as contact lens wear or radiation. So when we think about limbal stem cell deficiency, often these kind of eyes come to our mind. Opaque cornea with extensive pannus or neovascularization. But in the US, we often see many different type of presentations that based on the degree of the stem cell deficiency, and such as shown in these slides. In eyes with partial sectoral stem cell deficiency, meaning that only a sector of the cornea and limbus is affected, then they exhibit only the abnormalities in this location. This area often exhibit by stippling faucine staining or late faucine staining, such as seen in this one. This is due to lack of tight junction of the conjunctiva epithelial cells on the cornea. Therefore, the faucine will stain the basement membrane, and this dye will persist on the cornea for a longer period of time. In the more advanced stage, this sector that is affected could exhibit this wall-like staining pattern. There's lack of palisade vault, and the epithelium could become quite opaque. In total or subtotal limbal stem cell deficiency, patient can present with persistent or recurrent epithelial defect and vascularization of the cornea is often presented in these eyes. So what is the best way to bring out those signs of limbal stem cell deficiency? When we look at the eye using the bright light, we will not see those abnormalities. Only under blue light with fluorescent staining that this kind of pathology can be elucidated. For example, this is another eye that I did a dissect on, and however, her vision was limited to 2100. So when we stain the ocular surface, and you can see that the surface was quite abnormal with this vortex pattern extending towards the almost center of the vision. That abnormality, the irregularity, decreased the vision significantly. The key is to put in appropriate amount of fluorescein on the ocular surface. When there is too little dye, then the inadequate staining of the abnormal epithelium occurred, and we can see the pathology. When we put too much dye, then the stain pattern is completely covered by this excessive fluorescein liquid. So still, we will not be able to see the pathology. Like for example, in this eye, there was too little fluorescein put in. So when there was adequate amount of fluorescein was instituted, then the pathology was able to visualize. That's in a setting when too much fluorescein was placed and the pathology was masked, and when those excessive dye disappeared, and you can see this beautiful pattern of normal epithelium. However, not every patient come in with those typical staining pattern. For example, this woman came in after seeing 6 different cornea specialists, and she was given a diagnosis of limbal stem cell deficiency. However, when we look at this eye, this fluorescent staining pattern was very different from those that I have shown you. So the question was that, is this dry eye or this limbal stem cell deficiency? This is another case that I encountered several years ago. This 61-year-old female was given the diagnosis of a severe limbal stem cell deficiency in both eyes by clinical exam alone. And she was recommended to undergo limbal stem cell transplant or keratoprothesis. And ligament-related keratolimbo graft was chosen by the patient, being her brother being the donor. So she planned to have this procedure done in Los Angeles. So when she flew in to see us, and that's how she presented, this eye, in the right eye, that opaque cornea and 4 quadrants of neovascularization, and the fluorescent staining pattern was somewhat a little bit different from those that I've shown you. So we performed a confocal microscopy on this eye, and we found that in the central cornea, she had plenty of corneal epithelial cells, and in 4 quadrants of the limbus. She also had a good amount of limbal epithelial cells, except in the this quadrant that she had these goblet cells. So the diagnosis for her was that she had minimum sectoral limbal stem cell deficiency. Therefore, a keratolimbo graft would not benefit her much. Instead, she would have been subjected to systemic immunosuppression. So in 2019, a white paper was published by the International Limbal Stem Cell Deficiency Working Group. In this consensus, diagnostic testing was recommended to be performed, if all possible, before any surgical intervention. The diagnostic tests include in vivo imaging and characterization of cells from the corneal surface. In vivo imaging could be performed by an in vivo confocal microscopy and also anterior segment OCT. In vivo confocal microscopy can achieve single cell resolution. Therefore, you can see that in central cornea, the corneal epithelial cells are readily visualized. They are in high density with very distinct cell-cell borders. In eyes with stem cell deficiency, even in a mild stage, the cells become larger and the nuclei become more evident. And the cells become metaplastic in the severe stage. Often, any cells resemble limbal epithelial cell, corneal epithelial cells were not detected. A similar observation was made in the limbus. And this is palisadable. And in eyes with stem cell deficiency, the palisades often are absent, and as well as the limbal epithelial cells you've seen over here, accompanied by an influx of inflammatory cells. How to quantify these changes? We first look at the basal epithelial cell density. In the central cornea, the density is around 9,000. In eyes with stem cell deficiency, you can see that the cell density declined, and the degree of decline proportionally to the degree of the clinical presentation. We also noted that the epithelial thickness become thinner in eyes with stem cell deficiency. And OCT is pretty handy to look at all layers of the cornea. In normal cornea, and this hyporefractive layer indicates the epithelium, and the stroma is in the bulk of this structure. In eyes with stem cell deficiency, in severe deficiency, you can see that there is a lack of such a hyporefractive layer of corneal epithelium. In many of these eyes, a thick layer of subepithelial scar could be detected. In addition, this basal nerve density also declined as well. And in a study that includes 51 eyes from 37 patients with stem cell deficiency, the basal cell density, basal nerve plexus density declined significantly compared to normal. And in severe stage, in many of these eyes, the nerve were not even detected. So it is important to recognize that often these eyes have concurrent neurotrophic keratopathy. We just recently published a paper demonstrating that in eyes with limbal stem cell deficiency, the subbasal nerve density as well as corneal sensation decline. Therefore, supporting our hypothesis that these eyes have coexistent neurotrophic keratopathy. So, how to diagnose stem cell deficiency? This is a step-by-step algorithm. First, to obtain a comprehensive ocular history, then perform a very thorough slit lamp exam using fluorescein staining to look at the any abnormal corneal epithelium. If any suspicion of stem cell deficiency, then obtain an anterior segment OCT to evaluate corneal epithelial thickness. If indeed the diagnosis is highly suspected, then if the physician doesn't have the resources of expertise to manage this patient, it's recommended to refer this patient to eye centers with expertise on limbal stem cell deficiency. This center can perform in vivo confocal microscopy, as well as perform cytologic or molecular tests to detect conjunctival cells. In co-management of these complex patient, would be most desired. So next, I want to move on to the management of limbal stem cell deficiency. In 2020, a global consensus on the management of limbal stem cell deficiency was published by the International Limbal Stem Cell Deficiency Working Group. Because eyes with limbal stem cell deficiency often have comorbidities. Therefore, the first step is to manage these comorbidities before getting into the surgical treatment of this disease. So this can be achieved by a stepwise approach. The eyelid conjunctiva abnormalities should be corrected. Any ocular surface inflammation should be controlled. Any dry eyes should be also optimized, and any toxicity to the corneal surface should be also removed. And this is very essential steps of the management of limbal stem cell deficiency for threefold. One is to provide the best environment for engraftment and long-term survival of transplanted limbal stem cells. Second, it potentially can enhance the survival of the residual limbal stem cells in partial limbal stem cell deficiency. And lastly, these managements can improve patients' symptoms. I want to show you a case that illustrates how important of optimization of ocular surface. So this is an 84-year-old male with a history of multiple surgery due to glaucoma, and she also had BRVO in the left eye and complicated by CME. And he also had dry eye disease and was given a limbal stem cell deficiency in the left eye as well. He was on dozolamide and prednisone acetate in the left eye. His vision was counting finger in the affected eye in 2025 in the right eye, and that's how he looked like in the left cornea. He had 2+ conjunctival injection. The epithelium looked very irregular, and you can see that there was stippling staining of the fluorescein and as well as filaments. And this segment OCT show superior half, 2/3 of the cornea, I should say, had epithelial thinning as shown in this epithelial map. And confocal microscopy did not detect any corneal epithelium in the central cornea, no limbal epithelium in the superior limbus, but he had limbal epithelial cells in the temporal, nasal, and inferior limbus. So this patient was given a diagnosis of sectoral limbal stem cell deficiency, and is classified as stage 2B. Because he has such a severe dry eye and filamentary keratitis. So we place punctal plugs in lower puncta in both eyes, and then increase the prednisone acetate to control the ocular surface inflammation. We also recommended to switch his eye drop to preservative-free formulation, but he was not able to obtain due to insurance limitation. So 3 months later, that's what he presented to our clinic. The conjunctiva was much quieter. The ocular surface epithelium was much smoother. And you can see that in the fluorescein staining, the central cornea was largely unaffected. The superior limbus was still exhibit this stippling staining. His vision improved from counting fingers to 20/150 and in 3 months, and 20/80 a year later. So his stem cell deficiency improved dramatically. So after the ocular surface is optimized, then the next step, if the patient still have stem cell deficiency, then we'll move on to the next stage of ocular surface rehabilitation by limbal stem cell treatment. The treatment recommendation is based on the lethality and severity of the disease. I did mention about the staging, and this is the staging system that recommended by the International Limbal Stem Cell Deficiency Working Group. In stage 1, the central cornea is not affected, but there's various degrees of limbal involvement. In stage 2, the central cornea become affected, and stage 3, the entire ocular surface is affected. So in unilateral and bilateral stage 1 and 2A disease, in which central cornea is not affected, then observation, ocular surface optimization, medical treatments, and removal of the affected epithelium away from the central cornea could be considered. In severe stage 2 and 2B, the central cornea, in which central cornea is affected, and in some eyes, removal of this abnormal epithelium can improve the patient's vision. And localized, like sectoral, limbal stem cell transplant can also replenish the stem cell in those affected region, leading to improvement of the ocular surface. There are two main types of limbal stem cell transplant. One is through direct tissue transplantation, either from allogeneic or autologous source of the tissue. Select procedure is preferred over these old-fashioned conjunctival limbal autograft due to the concern of the compensation of the donor eye, as a larger amount of limbal tissue is required for this procedure. Cincinnati procedure is also advocated in total stem cell deficiency, in which allogeneic autologous graft and allograft can be combined together. And then cultivated limbal stem cells can be also used to treat stem cell deficiency. This approach has an advantage of requiring the least amount of the tissue. And conjunctival epithelium also is often necessary in eyes with conjunctival abnormality as well. When we look at the outcome of limbal stem cell transplant in the meta-analysis, we found that autologous limbal stem cell transplant, either by direct transplantation or through cultivated route, it has a higher success rate and lower complication rate compared to allogeneic source of limbal stem cell transplant. However, the long-term success rate has been lower than 76%, often is in between 50% to 76%. Randomized controlled clinical trials are necessary to compare efficacy among different therapies, because all these studies use different inclusion criteria as well as the outcome measure. So in eyes with unilateral severe stem cell deficiency, then autologous transplantation is a preferred choice. But in eyes with bilateral limbal stem cell deficiency, then allogeneic limbal stem cell transplant, keratoprosthesis, or all mucosal graft would be necessary. To achieve higher success or more prevalent use of autologous cells, and the ex vivo expansion of limbal stem cells on 3D cells is the first approved stem cell therapy, HoloClear. So, this therapy has demonstrated the safety and efficacy in many of the patients. However, there's disadvantage of this therapy that include presence animal product and limitation of the treatment only to unilateral disease. In the clinical trial, there was lack of standard outcome measure that demonstrated biological activities of the stem cells. So to overcome those limitations, our group has developed a xenobiotic-free and filter-free culture system that was spearheaded by Dr. Gonzalez. She developed this very simple culture system that can expand the stem cells within on average about less than 14 days. And during this process, she also developed standardized assay to quantify the amount of stem cells and cellular composition of these cultures. And this measure could be used to assess the quality and efficiency of different stem cell culture methods. So currently, we are running a phase 1 clinical trial, which investigates the safety and feasibility of these neo-cultivated autologous limbal stem cell under the xeno-free and filter-free condition to treat limbal stem cell deficiency. In addition, this trial aims to validate the limbal stem cell deficiency diagnostic criteria and quantitative staging system that we developed. As required by the FDA, this trial is a randomized, controlled, open-label study. There are 15 eyes in the stem cell treatment group and 5 eyes in the scleral lens treatment group, as shown over here. And I want to show you one of the success example that how we determined the degree of this limbal stem cell deficiency. And this in the left panel is the picture of the donor eye, the normal eye. The central cornea is clear, and this eye had high density of corneal epithelial cells, and the central cornea had a hyporefractive layer of corneal epithelium. At pre-op, the other eye and the cornea has scarring as well as abnormal corneal epithelial staining as seen in this picture. By confocal microscopy, no epithelial cells resembling corneal epithelial cells were detected, and there was lack of hyporefractive layer on the corneal surface, suggestive lack of corneal epithelium. At 6 months after the limbal stem cell transplant, you can see that the central cornea contained these corneal epithelial cells at high density. A layer hyporefractive epithelium was present, indicating presence of corneal epithelium. At 12 months, again, the survival of these transplanted cells was evident. Central cornea had clear high-density corneal epithelial cells, and the layer of hyporefractive corneal epithelium was present. So this is a proof of concept that using the standardized in vivo parameters, these eyes can be staged in a more objective manner. In the, bilateral stage 3 disease, then transplantation and allogeneic limbal stem cell graft or all mucosal graft could be considered. This is a diagram of how this surgery is often performed. The penis is removed, and then the graft from the donor is then transplanted into the recipient eye, and in the autologous fashion, and this is a graft isolated from superior and inferior, 3 clock hours from each, total 6 clock hours. In the allogeneic, then entire limbal region of the donor tissue, cadaveric tissue, will be sutured on around the limbal region. And all mucosal graft can be transplanted, like the limbal tissue, 360-degree, and or at designated location. The all mucosal graft is very one important thing about the all mucosal graft is that it needs the blood supply so that it can be engrafted on the recipient bed. So this is a patient who had persistent epithelial defect after cornea transplant due to chemical burns. And after all mucosal graft, you can see that 1 month later, the cornea was re-epithelialized by this oral mucosal epithelium. So the eye was stabilized. Keratoparesis is also a very useful means to restore vision in these eyes. And this is a patient who had multiple graft failure, and after 1 month, the patient achieved 20/30 vision. And eyes with poor tear function, then Boston type 2, osteoarterial keratoparesis or tibia keratoparesis would be the better option. So those are the currently available management for the treatment of limbal stem cell deficiency. How about where we're heading from here? As I mentioned, the success rate of limbal stem cell transplant plateaued at 76%. And in the last 2 decades, when some of the investigators look at the cell types from the eyes received allogeneic limbal stem cell transplant, and they often found that it was the recipient cells reconstructed the corneal surface. In addition, in recent years, mesenchymal stem cells were reported to be effectively reconstructing the ocular surface for a period of time. So the question is that what is the effects of the limbal stem cells and mesenchymal stem cell transplant? Did they provide trophic factors, or did they repopulate the limbal stem cell population, or both? If they repopulate the limbal stem cell population, then what is origin of the recipient limbal stem cells in those eyes were labeled as total limbal stem cell deficiency. In early years, I often do my own confocal imaging. So I noted in many of the eyes with stage 3 or total stem cell deficiency, they could have clusters of limbal epithelial cells as shown in these eyes, this typical eye. And she had a chemical injury at birth and had already 2 failed cornea transplant. Goblet cells were detected on the cornea. So clinically, she had total stem cell deficiency. However, in the inferior limbus, where it is this location, a lot of multiple patches of limbal epithelial cells were detected. In addition, in eyes with sectoral stem cell deficiency, as seen in this eye, and the limbal region often exhibit different structure, and these cords of limbal epithelial cells can invade deep into the stroma, and they become hidden in this more protective location. And one of my fellow named this as limbal lacunae. So limbal stem cells can remodel their external environment to increase their survival, and they're quite resilient. And even though clinically, the eyes may exhibit total stem cell deficiency, however, in half of the eyes that with stage 3 disease, limbal stem cell could be detected in our series. It's likely that these residual limbal stem cells reconstruct the ocular surface after allogeneic limbal stem cell transplant or mesenchymal stem cell transplant. So the future direction will be in these eyes, then rejuvenate the residual stem cells in eyes with residual stem cells, or replenish stem cells in eyes lack of stem cells. So the therapy in the pipeline is that to utilize the advantage of confocal microscopy that could detect any residual stem cells, then perform a targeted biopsy to remove these residual stem cells for expansion in culture, then transplant it back to the same eye or the other eye to reconstruct the ocular surface. In eyes with enough residual stem cells, there may perhaps topical therapies, topical eye drops that can promote the proliferation of these stem cells in the on the eye. That would be much more preferable than surgical intervention in partial stem cell deficiency. Reconstruction of the native limbal stem cell niche is necessary to achieve long-term survival of these transplanted limbal stem cells. Without their proper environment, these stem cells will not be able to survive long-term. But before doing any of this surgical treatment, optimization of the ocular surface is the first step in managing limbal stem cell deficiency. And a set of standardized outcome measure is necessary to objectively compare the efficacy across different treatment. Therefore, we will hopefully learn that in which stage and which treatment would be the best option for those eyes. I want to thank all the people who work with me on all those studies I just presented, and also the funding agency, California Institute for Regenerative Medicine, as well as National Eye Institute. So thank you so much for your attention, and I'm ready for any questions you might have.
Thank you so much, Dr. Deng. I'll allow a few minutes for some questions. I do have one. What challenges have you encountered in using in vivo imaging to detect limbal stem cell deficiency in more advanced stages of the disease?
The in vivo imaging, this could you repeat the question? I mean, using in vivo imaging to detect. Okay.
The more
Yes.
advanced stages.
Advantage. Yes. So for us, first we do a slit exam and to detect any abnormal epithelial cells, and then we use anti-segment OCT, which pretty much then all the corneal clinic will have this device. And once we confirm that the corneal epithelium is abnormal, then we move on to the confocal microscopy. And the in vivo confocal microscopy is challenging to operate, require quite a bit of practice to get proficient at it. Another one is the patient cooperation, because this is a lens right on your cornea. So some patients will have a little hard time get used to this contact nature of the exam. The other challenge is learn how to interpret the image that we see, so we published a few papers on how to recognize the corneal epithelium versus conjunctival epithelium, and also how to quantify the cell density. So, and this is not as difficult as people think. And we opened to other labs, to other investigators to come and observe how we perform this imaging, and then how to interpret these images as well.
We have a question. In pre-surgical stages, is there any role for autologous serum tears?
That is a great question. I have treated the eyes with partial stem cell deficiency with serum tears. The effect is somewhat limited. I think that it could be due to the severity of disease we see here in our center. But the serum tear is beneficial to the eye, but they don't really stimulate the growth of stem cells on the eye. So their function mainly is to treat the dry eyes and to stabilize the ocular surface. But I have not seen a case that improved dramatically in eyes with multiple surgery. However, in eyes with dysfunction of stem cells, meaning that the eyes still have a very good amount of stem cells, this kind of adjuvant treatment can increase the function of stem cells, and they can improve the condition significantly.
And then we have in cases of severe injuries and burns that cause both corneal scarring and limbal stem cell deficiency with superficial neovascularization, is it most advantageous to start with limbal stem cell transplant or PK first or combine?
That is an excellent question. So in the acute setting, the burns have to stabilize the injury, treat the injury first. And these eyes often have severe degree of inflammation and persistent epithelial defect. So those need to be treated in the acute phase. Once the corneal surface become stabilized, and then they will consider how to reconstruct the limbal stem cell population. We have found that in this acute or subacute phase, anti-inflammatory treatment like topical steroids and also those recurrent persistent epithelial defect should be treated aggressively, either by amniotic membrane treatment or tablet serum as mentioned, or Sophie to stabilize the eye. And then once the eye is stable, then move on to the stem cell transplant if needed. And for the degree of the deficiency, if it is unilateral, then autologous stem cell transplant would be more desirable than allogeneic transplantation. And for those thick pannus and or symblephalon, those should be corrected, as I mentioned. If any eyelid abnormality, if the conjunctiva also severely damaged, then conjunctiva transplant should also be part of the limbal stem cell transplant. That's why conjunctiva limbal graft is necessary for those patients.
In a patient with an incomplete Gunderson flap elsewhere, how would you assess limbal stem cell reserve?
So we look at the confocal microscopy. One thing that we learned over the last 10 years after imaging so many patients is that corneal neovascularization does not equal stem cell deficiency. And people tend to mistaken this kind of pannus or neovascularization as stem cell deficiency. But when just like the patient I presented, and this patient can have good stem cell function. So for those patients, superficial keratectomy will be enough to remove the scar and pannus without having a stem cell transplant.
How does your limbal stem cell surgical approach differ from the Draconis CALEC approach? Patient selection coming from a corneal endo guy, Jonathan Lass.
Yes, Dr. Lass, thank you for a compliment. For this CLET, that's what you mentioned, right? These cultivated limbal epithelial cell transplant.
Yeah.
Okay. The method that I'm using is very similar. So the way that we culture these cells somewhat different than what had been published by Dr. Ola Draconis, the group. They did a beautiful job and really reached a milestones that in the US. I culture the cells differently. We directly biopsy the tissue and then place on a denuded amniotic membrane and use a new media to promote the expansion growth of the limbal stem cells. The cells will migrate and grow over the amniotic membrane, and then we would take out the membrane once it reaches a certain size, and then we transplant onto the ocular surface. Before that, we will prepare the cornea by removing the scars and then recess the limbus, but I don't excise the limbal region because some of these eyes still have stem cells. So I want to preserve the stem cells. So I kind of do peritomy, but I don't excise the limbal tissue. I recess it and then put the amniotic membrane on the cornea, secured by a tissue glue, and I drape the peripheral conjunctiva over the limbal stem cell graft using tissue. I do take out the explant tissue and I cut in half, and half suture at 6 o'clock and another half suture at 12 o'clock. So I don't waste any of the tissue that I harvest from the contralateral eye, and then follow the patient. So this is how we perform the surgery.
And then we have, what are the worst drops to avoid for negative impact on ocular surface patients?
Could you repeat the question again? What is the negative?
What are the worst drops to avoid for negative impact on ocular surface?
Eye drops. Preservatives, they're terrible. They can eat up the cornea. If the patient have concurrent dry eye disease and even makes it worse. The first thing I do for this patient is take them out from any preserved eye drops. Artificial tears, glaucoma eye drops, I try to reduce the amount that eye drops placed on their eye. So that is number one I do. In addition, I have a very, very low threshold to place a punctal plugs in these patients. No matter how many drops they put in, if the punctums open in 2 minutes, this whatever eye drop they put into this eye will be drained out of the eye. So to enhance any eye drop like autologous serums, artificial tears, and then so first thing I would do is just put a punctal plugs in those dry eye patients and eyes with neurotrophic keratopathy as well.
Is there any role for Oxervate in medical management of limbal stem cell deficiency?
And I have not systematically looked at our data yet. My colleague, Simon Fung, and I did look at a small subset of those patients. And in some of the patients, indeed, there some benefit have been demonstrated. And I think this also really depends on the etiology of the stem cell deficiency. We do see a number of keratopathy related to Canavan square. Those do have both limbal stem cell deficiency, meaning the lack of stem cells, and also dysfunction of stem cells as well. And these patients tend to have neurotrophic keratopathy. So in those eyes that oxybate can be beneficial, but the effect is not long lasting. And recurrent corneal erosion can occur, and then the degree of stem cell deficiency can get worse over time after treatment.
When you use serum tears, what concentration do you use?
I like to use anything over 50% because the rationale is to give as many growth factors as possible. So higher the concentration, will better. Of course, there's no study demonstrates such a hypothesis, but kind of intuitively, you think, okay, let's give more growth factors. Let's give higher concentration of serum tears. And this is different from dry eyes. Dry eyes for lubrication. And lubrication, a lower concentration would be sufficient. But in these eyes, they need growth factors.
Do you avoid using serum tears in patients on immunological cancer treatment associated corneal toxic?
This is a really great question. I think that those patients, when they're very severe, they need to, often the FDA would ask them to try to stop the drug to stop. And then if they stop soon enough, the pathology can be reversible. But I have seen patients who sitting quite significant, longer lasting, these kind of keratopathy. Serum drop depends where they come from. If the patient have is undergoing chemotherapy, the blood has a chemo agent in it, and you put the serum on the eye, I think may not be very good idea. And if any serum drop that but I would prescribe, I would come from a family member or a donor source of serum eye drops.
And do you use immunosuppression after allogenic transplants?
Absolutely. The limbal tissue is not immunoprivileged. In fact, they're very quite stimulating because they're MH1, MH2 as well, and they're highly vascularized. So they should be treated like an organ transplant. As clearly demonstrated by Dr. Ed Holland, his group done beautiful studies on over and over again supporting the use of aggressive immunosuppression for this patient. And in order to have a higher long-term outcome, then this patient require a co-management with a renal transplant team.
I believe that is all of our questions.
Great. And
one more. How long after a stem cell transplant should one wait prior to considering PK for visual rehabilitation?
I think that by from what we've seen from the transplant we have done, either vivo expanded or the direct transplantation, I think that by 6 months the ocular surface become quite stable, and then I think by then cornea transplant could be performed. I mean, it could be done even as soon as like 4 months later, but it's better to have the stem cell have a good chance, a good length of time to survive in graft first before you stress the eyes by removing a lot of cornea epithelium. Because by removing the epithelium, you kind of make the stem cell to divide and to proliferate, and then migrate onto, the mature cells migrate to the cornea. That is another stress to those stem cells too. So for me, I think that give you some time for the cells to settle in graft, and then enough time for them to be able to sustain the wound healing for a 8 millimeter cornea transplant.
Is there any experience with Descemet membrane anterior keratoplasty in cases of partial limbal stem cell deficiency?
Sorry, I got distressed. Somebody calling me here for my OR. And can you repeat the question that's come from the OR whole day?
Any experience with Descemet membrane anterior keratoplasty in cases of partial limbal stem cell deficiency?
Yes, I don't have my personal experience, but the idea I think is sound. The idea to reconstruct the niche, and the basement membrane appears to be a good substitute for the stem cells to settle and then grow, survive on the Descemet membrane. So I will welcome a larger study to compare head-to-head with other standard treatment to show the advantage of that. And I think that this time we don't have a standard of pair algorithm for these patients. So I think it's be really important to compare the efficacy across different approach using a standardized parameters to evaluate, to quantify the outcome measure. And that's why at this point, I'm working with working with the International Limbal Stem Cell Deficiency Working Group to establish a standardized criteria for clinical trial. So I think that I'm really excited that we just had a meeting at a World Cornea Congress, and hopefully that we will have we'll make more progress, and hopefully in a year we'll be able to come up with a consensus on the standardized criteria for clinical trial.
And we have a question from your co-fellow. Do you happen to know if anyone is working on topical fingolimod MS drug eye drops for stem cell proliferation?
I know a few clinical trials that initially aim at persistent epithelial defect or neurotrophic keratopathy. As for stem cells, I think that I'm sure there's clinical trial to look at the secretomes for mesenchymal stem cell, whether they can promote the survival of the residual stem cells or partial limbal stem cell deficiency. And my understanding is that the trial that looking at the transplantation of mesenchymal stem cells themselves on the limbal stem cell deficiency, the long-term outcome was not as promising as the transplantation of limbal stem cells. Most of these grafts fell after a few years. So that's kind of suggests that in eyes with severe stem cell deficiency, they still need replenishment of the stem cell population. And mesenchymal stem cell might be able to provide some trophic factors for them, for the residual stem cell to function better, but in the long run, that is not sufficient to reconstruct the entire corneal surface or produce enough stem cells to repopulate the entire corneal surface.
And then what about using Bowman layer instead of DMAC?
Bowman layer is interesting because when you look at the structure of the limbus ends at the Bowman's layer. So that means that and Bowman's layer is mostly on the central cornea. So stem cell has many signals that regulate their survival and proliferation. One of them is mechanical stimulant, like the stiffness of these extracellular matrix also dictates or regulates the stem cell fate. So when you put these stem cell on a substrate that has very different stiffness, like different more stiff or less stiff, then the phenotype will change. They may become more differentiated. So for Bowman's layer, I have not tried it yet, but because when you look at anatomy of the eye, Bowman's layer does not support the limbal stem cell, native stem cell niche. So I cannot say that it will, I cannot say it will not because I have not done the research to support it, but my guess is not as good as the soft tissue in the limbal region.
Great, I think that is the last question, and we're ending right on time. So thank you everyone for joining, and thank you, Dr. Deng, so much for your expertise. As I mentioned, look out for a brief survey at the end of this webinar, and then look out for our next one, hopefully in the fall.
Thank you so much for giving me the opportunity to share our research and our experience with all of you.
Thank you. Everyone have a good night.
Good night.